Hey Trude, how you doing?
Fine, thanks. How are you, Carol?
I'm good. This
Nice.
webinar is a good reminder. It's time for me to come and do all my women's
Check
health
out.
things. It's good for all
Yeah,
of us, isn't it?
exactly.
Thank you very much. We see we have visual and audio there, Trudy, and we only have audio on you, Prof Ben. I don't know
You
if we're
don't
going to
have
get
better.
don't have a camera from you yet. In the meantime, let me start off by explaining this is our first of a series of webinars that we are going to be doing with the Breast Health Foundation. And thank you to them, as always, for organizing this and setting this all up together. It's a lovely initiative, spreading a little bit more information. Uh, the main theme of our webinars going forward are going to be on the Big Five, keeping it truly South African. And it's a Big Five with a twist. Tonight, we're starting off our run of the Big Five of women's health, and in particular of female cancers. We're going to be talking on a number of different topics tonight, such as cervical, ovarian, uterine, vaginal, and vulvar, which is why we got in the specialist was the immediate name that came to Prof Ben's mind when she said we needed to invite someone was Dr. Trudy Smith. I don't know if you want to go and give us a bit of a background of yourself, Dr. Smith.
I am a gynaecologist. I'm a gynecologist, an obstetrician, and a gynaecologist. So I deal mostly in gynae cancers and precancers, in fact, as well. So pap smears, abnormal pap smears, etc. I work at Wits Donald Gordon. I'm a Witsie by training. And I'm very grateful for this opportunity. It's my favorite thing to do.
Fantastic. That's great to hear. And not that we need an introduction, but Prof. Ben, please, once again, you've hosted many of these webinars, but let's give a bit of a background for you and your interest outside of breast potentially and other female cancers and women's health.
Well, women's health is a big thing for me, and it's an absolute pleasure to have a very good friend and colleague, Dr. Smith, on. I hope you guys can see me. I can see me. So if you can't see me, that's probably a good thing, but this is how it is. And my interest, I'm a gen surge by training, also a Vitsi, and obviously, you know, the breast is a part of the body, and we mustn't look at it just in isolation. So when we're talking about women's health, we must talk top to bottom. We must make our women safe. And like Trudy, I think an opportunity to speak to people in public is hugely important, because it's not just about doctor training. It is about every aspect. It's about equipping you with what you should do and how you should check yourself to make yourself safe. Right. I'll let you guys start. I've got a nice IT youngsters come up to see why no one can see me. There we go. Okay, Trudy, you can start off. Dom,
We'll
I
see
think
you in
you've
a
got
moment.
questions.
So
Yeah.
how we structure these webinars, Dr. Smith, to keep you up to this, we have a number of questions that has come through from some of our viewers, and the most common questions that we receive in terms of the BHF's foundations with people out there. I get a list of these questions brought in. I can prompt with some of these questions to be asked, but feel free to take it away, go off script. If you feel like a question needs more than just a simple answer and explanation behind it, go wild with that. I'm going to start with some very common questions that are out there, and then we'll split into some different categories. First off is a bit of a stats from myself, from Prof Ben and you. How common is cancer in women, and what are the most common types of cancer?
So for me, obviously breast cancer is the commonest cancer that affects women, but in fact, cervical cancer kills more women than any other cancer, and particularly in our country. And for us, that's a real travesty, because it is 100% preventable. So after cervical cancer, and the cervix is the mouth of the womb, that's what holds your baby in, that's what lets your sperm in. And that's what makes us women unique, because that is the only connection. You know, men don't, their inside body doesn't have a connection with the outside world. And our inside body does, because we've got to let a sperm in and we've got to let a baby out. So the cervix, which is the mouth of the womb, is the commonest killer of women in South Africa, and unfortunately young women. So that for us is a big problem. And then endometrial cancer, that's the uterus, the lining of the uterus, and that is the second commonest cancer. And that is the second commonest cancer because it's often related to obesity or being overweight when you're older. And then the third commonest cancer is ovarian, so that's your eggs. And then now up and coming, unfortunately, is vulval cancer. So that's cancer of the lips, your vaginal lips, and that's also HPV related. So we're starting to see a lot more of these cancers.
So Trude, I love the fact that you say that cervical cancer is preventable. And I think to start even before diagnosis, it always interests me. You have a whole lot of, I think, new vaccines and everything. And you have people sit on either side of the fence in terms of vaccines. I'm a very pro-vaccinate for anything, including children who want your credit card, and and try and make sure that we protect ourselves. So where do we start?
So we start in adolescence, and we start by vaccinating both boys and girls if we can. So in South Africa, government now pays for both private and government school girls to be vaccinated. Unfortunately, with a vaccine that doesn't, I mean, they vaccinate them, let's just put it that way. And the vaccine, sorry, I've got very noisy dogs. Stop it. The vaccine is given to girls in South Africa for free now, a single dose in the last year of primary school. That's when it's advocated. But basically, you can vaccinate both boys and girls from 9 to 16 years of age. And they are basically now a single dose of the vaccine. You don't need more than one dose. So that also makes it much more cost effective. So the vaccine's been around for a very long time, since 2008. And in Australia, it's mandatory. In Italy, now they've made it law. And there are very few side effects from the vaccine, I promise you, apart from a sore arm. I have vaccinated my children and myself. So, and you can vaccinate older women. It is licensed up until 100 years of age.
So me too. I've also vaccinated everyone in the family. In fact, my staff as well. Anyone who I come into contact with, I push, vaccinate. I often get asked by patients, oh, well, you know, my daughter is only 12 or 13, and why does she need a vaccine? Because she's a good girl.
Well, unfortunately, HPV lives everywhere. You can't avoid it. And human papillomavirus is the precursor to cervical cancer. We are all of us, every single one of us, going to get an HPV infection sometime in our life. Most of us, thank God, will get rid of it. But some of us, our immune system can't get rid of it. And it's when it persists that the problem is there. So all of us will get HPV. The only way you'll never get HPV is to never put a single thing in your vagina. We're talking no penis, no finger, no lips, no nothing, no vibrator. Even women who have sex with women, etc., are at risk. We must not think that it is a nasty, dodgy thing. It is just, it lives everywhere. You can't avoid it. And we don't know whose immune system's not going to be good and whose immune system is.
And Trudy, you know what's interesting for me? It's I think we know that when your immune system's strong, and we vaccinate people when younger, then it's better in terms of when they're older. And a little aside is it actually decreases risk of head and neck cancers and other cancers elsewhere.
So, you know, my daughter is busy doing ENT at the moment, and she's horrified at how many patients have throat cancer and head and neck cancer. And, you know, it's also another cancer that's not spoken about very often, and it's becoming much more common. So it is a cancer vaccine. It protects you against anal cancer, penile cancer, cervical cancer, vulval cancer, and throat and palate cancer. I mean, it's phenomenal. Absolutely. There's no other vaccine that protects you as much, as HPV. Everybody should be vaccinated.
And then tell me now, there's Gardasil 9. So I mean, I vaccinated everyone, like I said, family and staff, with Gardasil 9. I wasn't quite sure if some of the youngsters, if they've been vaccinated previously with other Gardasils, well, do you now then use it as a top up or what?
So the government is giving Cervirax. That is, so let's talk about the HPV. So there are many HPV types, but there are probably round about 16 types that cause cervical cancer. But there's the top two, that's HPV 16 and 18. They're responsible for most of the cancers, 70% of the cancers, 70% of anal, of cervical, of vulva, of the throat ones. But there are other variants that cause cancer. So before we had a vaccine that just contained two types. Then we got a vaccine called Gardasil, which contained two genital warts ones, plus two cancer vaccine. And then we got Gardasil 9. And Gardasil 9 contains 2 for genital warts and 7 for the top 7. So it'll protect you 95% of HPV-related cancers if you use Gardasil 9. So if you were vaccinated with Cervirax, for instance, at school, or if you were vaccinated with Gardasil 4, you certainly can have Gardasil 9 as well. But unfortunately, we don't have much data that you can give a single dose to older people. You would still need to have 3 doses in older people. But if you're still young and you are up to the age of 14 and you got a Cervirax, you can have 1 single dose of Gardasil 9 and it'll give you that added protection. So the only unfortunate thing is obviously the 9-valent or the Gardasil 9 is more expensive than the other 2. But the other 2 are the same price. So if you had a choice, then you would rather have the Gardasil 4 if you were, struggling than the Cervirax. So it makes it a little complex, but if you want the Bentley of vaccines, it's the Gardasil 9.
Fantastic. Thank you very much, Trudy. And this is absolutely fascinating. You've covered a huge range of questions that I've already received around cervical cancer and HPV vaccines going into this. I wanted to take a moment and just have a little bit of a tangent now. We welcome anyone who's attending the meeting to send in any questions or specific queries to our speakers and see if they can answer them. And I'm going to take this opportunity to ask one directly to you because it sort of relates to our wide range of cancers, but coming more from a breast cancer into other types of female cancers. We have someone who mentioned that they were diagnosed with an ER-positive breast cancer about 2.5 years ago, 46-year-old, and they said they're done having children. What they were worried about is they were thinking about having a hysterectomy because they're scared of getting cancer in any other parts of their body. What would your comments be around that concern?
So, what my concerns are, and I don't know, Carol, I'm open to criticism, but surgery is a big thing. And, to have surgery for in case is a bigger thing. If you have a hysterectomy, remember that this is abdominal surgery. This is where you can damage the bowel, you can damage the bladder, you can get sepsis, you can get a clot to the lungs, and all manner of other issues can occur. And, we don't remove things in case. We remove things because they're high risk or because they need to be removed. And that, it would be my concern. I don't know what you think, Carol.
No, I fully agree with you. Okay, so it's technically more dangerous getting in your car and driving home in Johannesburg. So I think that it's trying to differentiate from having been diagnosed with a cancer and are you at risk for other cancers. And even then, you want to treat the cancer that you've got properly and screen carefully. So screen for everything. Check your breast, check your skin for moles. I know when I see Trudy, she checks me from top to bottom, even though she's got to just check the bottom half. And I think what you want to do is go for your scopes and just be aware of your body. But don't go around just saying, I'm going to operate on this just because of the in case. I think you're 100% correct, because that's when you land up with potential side effects and a lot worse.
Yeah, it would be terribly tragic if you developed a major complication from a surgical procedure that you actually didn't need.
And you operate to drop your immune system.
Yes. Absolutely. Yeah, you drop your immune system, you put somebody who already has a cancer at risk, for instance, of getting an embolization to their lung, getting a clot to your lung, because you're at increased risk of that. So to do what we call prophylactic surgery is done for certain conditions.
And Trudy, what girl checks would we do? So if you've got like a 22-year-old girl and she's at varsity, what must she do? What must the rest of us do? How often do you see? Who do you see?
So the important thing is that you should know your own body. Number one, learn about your own body and know about your own body. So we don't start, for instance, I'm sure everybody's heard about a pap smear. So and it's only called a pap smear because the dude who invented its name was Papa Nicolau. So we no longer do what we call a straightforward pap smear. And a pap smear is where we take a scraping of the cells from the cervix. What we do now is we do primary HPV testing. So we do like a pap smear. We look in your vagina. And in fact, now you can self-test for HPV as well. You can do your own test as well for HPV. So we put in a thing called a speculum. This is a thing that opens up the vagina and it looks for the cervix, the mouth of the womb. And we take a scraping of the cells and we send them away for HPV. And you should start that at the age of 25. That's what the guideline is. Because before 25, a lot of young girls are going to have a lot of HPV because they're certainly getting more action than I am in my old age. But
yep,
the majority
on that.
Yeah, you'll concur on that. The majority of young girls will get rid of HPV. So we don't want to over-screen. We don't want to scare people. So from 25, you have your first HPV test of your cervix. And if you're HPV negative, in fact, you don't need another one for 3 to 5 years. So because HPV needs to hang around for a long time to cause a problem. Then the other things like checking for ovarian cancer and uterine cancer come much later. But when you do see a practitioner, they can do a scan and they can look at your uterus and they can look at your ovaries. But your pap smear, you only need to have every 3 years. If you're HPV, we do primary HPV testing. And you don't need to do that earlier than 25.
And then in terms of your gynae check, so if you're going to self-test and you're going to go and see your GP and your GP is going to do a pap smear or clinical associate or your nurse at the clinic, etc., then the other tests, okay, I always recommend that people see their gynaes and let them have a good look because, with that transvaginal ultrasound, you're checking the uterus, you're checking the ovaries, and you're having a good look outside. For somebody who's just at home, is it worth their while? I always say, like you said, know your body. Do they sit with a little mirror and go, there's something concerning? I'm always surprised how many ladies I see that they've got melanoma on like the vulva or something, and you think, gee, that's an unusual place, but it happens.
It definitely happens. Thank God it's rare. Thank goodness it's absolutely rare. Unfortunately, the screening in terms of doing a scan is not a very good one, especially for ovarian cancer. You could have normal ovaries today and in 6 weeks' time have totally abnormal ovaries. So it's not the greatest screen. But what is more important is if you have irregular bleeding, you need to see somebody. Don't think that it's normal. Like I had a lady today who's 65. She says, I bleed occasionally. I'm sure that's normal. I'm like, no, that is not normal. When you are Menopausal, you've had your last menstrual period ever. If you bleed after that, you have to see somebody. It is not normal to bleed in your menopause at all. It's not normal to bleed after intercourse.
Yeah, those are all very, very useful tips that I think it's important for our ladies to know about.
Yeah, very much so. And if you know, it's expensive to go and see a gynae, and if you can't afford to see a gynae, then you have to, are your periods regular? Have you had your HPV test? If they are irregular, then that is something that you need to do, is have a scan. And if do you have a family history? Family history is really important.
Is there any way that we can check for ovarian cancer? Because obviously we see a subset of breast cancer patients have at higher risk for ovarian cancers. And I mean, I'm always surprised when I see people say to me, we have swelling of our tummy and we have pain in the lower parts of our abdomen. And I'm like, oh, hop up the
Prof,
road.
can I just interrupt you there? And apologies for this. We will definitely get back to the topic on ovarian cancer. I just want to try and structure our discussion a little bit more and wrap up on cervical cancer, and we can move on to some of the other ones.
No problem.
Part of the discussion that I haven't yet heard, and this might just be my own foolishness coming from a very breast health related involvement, is what are the treatment regimes for cervical cancer? Like, I know for breast you'll have surgery, chemo, and so on. Is it a similar type of structure?
So let's start with, we should not be getting to cervical cancer. So cervical cancer is so unique than other cancers in that you get a pre-cancer. You get a thing called a pap smear abnormality or a high-risk HPV with a pre-cancer. So an abnormality that if you treat it, you will prevent the cancer. So what are those treatments? So I run a dedicated outpatient colposcopy clinic, and everybody's absolutely terrified. And you guys are all welcome to go onto our website. It's ladydocs.co.za. So it's ladydocs with an S on the end.co.za. And that tells you a lot of information about HPV. So say you go for your HPV screen, and they show that you've got a high-risk HPV. It's an HPV type 16. And then the doc looks at it, the slide that they took, and he says, no, they are abnormal cells. That does not mean you have a cancer, but it can mean that you have a pre-cancer that needs a treatment. So it's very simple. As an outpatient now, we look at your cervix with a big microscope. So we get up personal with your vuvu, and we paint it with some dyes. We paint it with vinegar water and with a dye called iodine. And then we can see that abnormality shine up. And we show our patients the abnormality. And then we either take a little biopsy, or the treatment's very simple. You inject the cervix with local anesthetic, like when you go to the dentist, and we scoop out those abnormal cells, and we prevent the cancer before it even happens. And that's why you go for a pap smear. You don't go for a pap smear to find a cancer. You go for a pap smear to find a pre-cancer that can be treated so that you never get a cancer. So that's the first thing. Then what happens when you do happen to find a cancer? Well, the cancer is staged like everything else. And if you have an early one, you can have surgery, which unfortunately involves a radical hysterectomy. That means taking out your uterus and the cervix and the lymph glands. But if it is later, then you need to have radiation and chemotherapy to that area. I hope that helps, Dom.
Thank you very much.
Really helps. So Trudy, I mean, I recently saw a lady with a breast cancer who also had a cervical cancer that was treated with radiation and chemo. When do you, so if it's more advanced, you're going to treat with radiation and chemo, and then do you never need to operate?
No, because what happens, unfortunately or fortunately, is we're very successful at treating cervical cancer with radiation and chemo. And what happens with the radiation is it makes that tissue very, very hard. in that area. And the cervix, in front of the cervix sits the bladder, and behind it sits the rectum. And if you operate after radiation, you damage the rectum and the bladder. So we would only operate after radiation if it comes back in that area. But if it comes back in that area, we do a really big operation called an exenteration. So we take out the bladder, the rectum, the uterus, the cervix, the vagina, and then you get a bag for your stool and a bag for your urine. So that is really quite a radical thing if it comes back. But our success in radiation and chemo, even in a stage 3 tumor, is over 80%.
Sure, that's excellent.
Yeah, it's good.
I'll have to book my appointment sooner than later. You know, the thing is, and I think for everyone, you go through, life goes by so quick that when you realize when you got for what test and when, be it your mammogram or your mole mapping or your gynae test, you suddenly realize time has gone by. And I think everyone who's sitting on this forum must have a look and say, it doesn't matter. Just go in and have your checks and have your investigations done. The next thing I wanted to ask is, I often get asked by youngsters, I've had a positive HPV, can I have the vaccine?
Yes, you can still have the vaccine, because the first thing is, if you're vaping, you must stop vaping. You must stop vaping and you must stop smoking, because vaping and smoking prevents you from clearing any virus, and particularly the HPV virus. So I say to youngsters, how do you stop yourself from getting it back? And if you clear it yourself, or I have to do a treatment to get rid of it, how do you stop yourself from getting it back? You vaccinate. So in fact, we even vaccinate older women, 60, 50-year-olds who get abnormal pap smears. We have to do a treatment, we vaccinate, and that prevents recurrence. It does not treat what you've got. I think that's important. You have to note that it does not treat what you've got, but it prevents you from getting it back.
Yeah, I think that's important, because I think I'm often asked, it's a bit like with shingles, you know, I've had it before, what's the point of me vaccinating?
Yeah.
And I think we need to encourage vaccination.
Okay.
Agreed.
I have one more question to address, and this is probably going to appear at the end of every single discussion for the different categories we have. And since you have explained to me there's almost 2 different stages in terms of getting cervical cancer, it's that HPV aspect with abnormal cells, and then the cancer. What is the impact on childbearing? Can you have childbearing after having this treatment, after having HPV, after having cervical cancer?
So in terms of, if you've just got an abnormal pap smear and an HPV infection and you need a treatment for that, childbearing is not a problem. It does not prevent you from falling pregnant. If you've had several treatments to your cervix, there's a small chance that it can shorten your cervix, in which case you're at higher risk of having a premature delivery. But in those patients, they would have their cervix measured, and a stitch would be put in to hold the baby in. But certainly once you get a cervical cancer, unfortunately, childbearing will be almost impossible. There is a procedure where they amputate the cervix. It's called a trachelectomy. We do it, unfortunately, in very few patients, because usually they present much later. So childbearing becomes really difficult once you've actually got the cancer. And in fact, at the moment, I've got a 34-year-old who's been diagnosed. So what we did is we've sent her immediately off to harvest eggs so that we can now treat her cervical cancer. And unfortunately, to have children, she'll need to have a surrogate.
I think that just stresses even more catching it early, doesn't it?
It does. Well, going for your checks. Go for your checks. Vaccinate and go for your checks.
Thank you very much. I think we've discussed a lot on cervical cancer now. You mentioned that the second most common cancer was uterine or endometrial cancer. Is that the same thing? Are those different cancers looped into one category?
So there are some rare uterine cancers. They're called sarcomas. They really are very rare. The commonest one is an endometrial cancer, and the endometrium is the lining of the womb, of the inside of the womb. So it's a very interesting thing, the uterus. The uterus is a dynamic thing. You know, the lining changes according to hormones, and it's very estrogen receptor sensitive. So if you have too much estrogen and not enough progesterone when you have a uterus, it puts you at risk of a uterine cancer. So when you're a little bit porky, like I'm a little bit porky, our fat cells make estrogen. And we have, in fact, fat is called the third ovary. And I'm sure Prof Brain will also tell you that even obesity, unfortunately, puts you at greater risk of breast cancer. So the third ovary stimulates your uterus all the time. And when you are stimulated with too much estrogen and not put into check with progesterone, your uterus can develop a cancer. And that becomes an endometrial cancer. So it's common in patients like with polycystic ovaries who don't put themselves in check, and when you're a little overweight.
So Trudy, you know, this is so interesting for me because one of the biggest concerns I have with patients on tamoxifen is, oh, I'm going to get, and they often mistake it, an ovarian cancer, okay? And that's because tamoxifen is a SERM, and it actually has an estrogen positive effect on the uterus. What I'm also interested in is I have had a run of patients who are taking estrogen because someone's read about HRT, estrogen only being better for whatever, breast, etc. And then what they're doing is using a little bit of progesterone to rub on. And then what happens is I've seen, and they've got this massive thickening of the uterine lining. In fact, I've diagnosed 2 breast cancers who actually need to start their oncology treatment. So this is another problem that's going to have to be addressed. So I don't know if you just want to touch on that, because I think that's quite important.
Okay, so let's talk about the elephant in the room, and that is progesterone creams. So first of all, progesterone. Okay, so there are two things that keep the uterus in check. There are progesterone, which is naturally made by the body, and then there are progestogens. They are synthetic type of progesterones. So unfortunately, there's a move for people to use a progesterone cream and take estrogen for their hot flushes or whatever. We know progesterone, the natural progesterone, is not absorbed through the skin. It is not well absorbed. So if you are using a progesterone cream, you are putting yourself at severe high risk of estrogen endometrial cancers. They are not safe. They are unregistered, unlicensed, and unsafe. So too are what we call bioidentical compounded progesterones. I see at least 5 or 6 endometrial cancers in patients who are on bioidentical progesterones because there are no trials that have shown that that progesterone actually protects your endometrium. So if you want,
I love that. Yeah, I love what you're saying.
Yeah, if you want a proper natural progesterone, there is a licensed, registered, proper progesterone, but it's taken by mouth, orally. And that protects your uterus because, and progesterone is very interesting. If you are flushing and you're older and you need to and you want to take hormone treatment, you must take your progesterone orally at night. It helps you to sleep. It works on GABA receptors. But we know from trials, good trials, that if you take estrogen you need a minimum dose of progesterone, licensed progesterone, of 100 milligrams a day. Or if you are taking it only for 14 days of a month, which you should not be, by the way, because that also increases your endometrial risk, you need at least 200 milligrams a day. So there is a definite science to this, and you must not measure. There is no measurement of bloods of so much progesterone and so much estrogen. And Carol, you'll know, like you'll see somebody with an estrogen of 50 and another person with an estrogen of 50, and one is flushing like, schwitzing like you can't believe, and the other one's not sweating at all. What does that tell you? It tells you it's about the receptors. We can't measure the receptors, guys. So it's not about the level in your blood. It's about using the lowest available, registered, licensed stuff that sorts out your symptoms.
So Trudy, I'm so with you. So firstly, I'm not anti-HRT. HRT, hormone replacement, is a fertilizer. If you fertilize cells at a receptor, okay, you fertilize the roses grow, the weeds grow a little faster. That's why you scan and check your breasts and check everything. Yeah. And I think this concept, when I talk about bioidentical, I do it in a very blunt, simple way. I turn around and go, hold on a moment. When you fertilize the roses, whether you use 3-2-1 or Margaret Roberts, no offense to her, herbal thing, you fertilize the roses and the weeds will grow. The weeds are not caused by the fertilizer. They're either found in the soil. This is very blunt, saying something around the genetics, okay, or a bird plopped from the sky and that's why you got your weed. So that's why you screen your breast, okay, and you manage your symptoms. But don't be fooled that I'm taking something that's natural or a supplement or vitamin and I'm taking it transdermally through my skin, therefore it's safe for my breasts or this, etc. See a professional who has an interest in the field who can advise you on what is best for you, because we are all different, okay? And I do like, Dom, that you put up a picture of me probably from about 10 years ago looking skinny. For some reason my camera's not working, which might be a good thing, okay, because I've just called out a theater. But the concept is, okay, is that you're unique. You are a unique person and you need a specific formula for you to ensure that you have a healthy screened life. So,
and the most important thing is nobody must give you any hormone until you've had that mammogram. Nobody. You do not take HRT without a mammogram first. Ever.
Thanks. And you screen and you check. And yes, it's a more fertilized tissue, so it's denser. So you see specialists in the field, see your gynae, you check your breast once a month. And remember, when you go for a sonar, they lift your arms above your head. When you check your breast, relax your hands at the side so you can feel all those little fat rolls in those glands. I always say stand naked in the mirror. It's harder as we get older. Everything heads south, whether you're skinny or not. I mean, I look like a pug. There's so many little rolls on my rolls, okay? And check that your nipple's not pulling in. I discussed a lady in a radiology meeting today she had puckering and pulling in of the nipple and a supposed normal mammogram and ultrasound, okay? So you go and you review and you check. And if you are concerned, don't be worried about asking for other opinions, going to see specialists in the field. Go chat to people like Trudy, make sure you have a thorough checkup. And sometimes you need to do that once every couple of years, and that makes you safe. But that's very, very important from a woman's health point of view.
Carol, you made a lovely comment there about screening and checkups and everything. But what I wanted to know, and from my limited understanding of biology, is I'm assuming the signs and symptoms and the screening progress for uterine and endometrial cancer must be very different to cervical that we spoke about. Is there anything to look out for? Is there a sort of screening program? How would this actually be diagnosed?
So you can't screen for endometrial cancer on a pap smear. That's very important. You know, lots of patients say to me, oh, but my pap smear was normal. No. So endometrial cancer Number one, if you have irregular abnormal bleeding or you bleed postmenopausally, you have to be seen. Anybody on tamoxifen needs to be seen regularly. And we measure the thickness of the lining of the uterus, the endometrium. We use a scan through the vagina and we do what's called a transvaginal endometrial thickness. And that's the screening that we do for endometrial cancer.
Okay, thank you very much. And then in terms of treatment regimes, is this similar to breast cancer? You mentioned it was very ER/PR dependent. What is the treatment regimes available for endometrial cancer?
So quite interesting, endometrial cancer also has a pre-cancer to it in some patients. So you can have a pre-cancer that shows you have got too much estrogen and it's about to become a cancer. So the treatment for an endometrial cancer is generally surgical. So we would remove the uterus and the ovaries and we would take out lymph nodes. Like a sentinel lymph node. That's the lymph node the cancer first goes to, the same as in breast cancer. And then it depends on what that specimen comes back at, whether you need extra radiation or chemotherapy.
Okay, and I think from that I can infer the answer to my next question as what is the impact on childbearing that endometrial cancer has?
So in
young people, Trudy.
So yeah, we've had a few young patients, so it is very rare. We can manage conservatively. In other words, what we have done with those patients is we've put them onto they have to have a very early cancer. We've put them onto high dose progesterone, and then we've done a scope. And only if on scope there's nothing in the uterus, we make them pregnant immediately. And then we remove the uterus after the baby. But that is very rare special circumstances. And it's not common in young women.
Okay, thank you very much. Prof, if you have any last comments on endometrial or uterine cancer, I think
I'm going to encourage people to take their endocrine treatment, whether it's an AI and aromatase inhibitors do not cause thickening of the uterine lining. Tamoxifen does because it's not an anti-estrogen. It has, in fact, often the side effects, the DVTs and the endometrial thickening is more related to the estrogen positive effect of it. But I am going to encourage people to take their medicines and go for their screening.
Absolutely, without a doubt. The data is so robust on tamoxifen for breast cancer. You must take it.
And from what I can understand, listening from the outside in, is there are medications you take alongside the progesterone that helps to combat any of the negative side effects.
In fact, Trudy might even want to touch on, in fact, some of our patients who are really, really battling with their breast cancer side effects on their around their cancer. There's even some data. I know Judith did a very nice academic for us on that. We can actually even use low dose on the HRTs, etc. So remember, you are individuals, and if you are battling around symptomatology before stopping treatment, make sure that you have a good multidisciplinary review, and we understand and we treat everybody on a single person-by-person basis.
Absolutely, because one of the biggest problems with tamoxifen as well is a very dry vagina. And, you know,
no one should have that. Do you know my youngest child muted me on a webinar because I mentioned that I might have been in menopause for a while, but vaginal estrogen is the secret to great sex.
It is the best secret, and you can buy it over the counter. You deserve good sex. We all do.
Absolutely.
So, out of just curiosity, and now this is coming from a male just hearing this and everything, is vaginal estrogen, is there an age you should start taking on it? Should I mention it to my partner? Too young, too old? Is there any circumstances around it?
So there are even some contraceptives, like for instance, if you have a Mirena, If you are on a progestogen-only contraceptive, you can get a very dry vagina. A lot of antihistamines dry your vagina. So in those patients, we also use post-delivery after you've had a baby. I mean, it's almost physiological that your vagina gets dry. I always say to the patients, it's like the Kalahari Desert, and it deserves a bit of a sprinkle of water, and that sprinkle of water is estrogen.
Very interesting.
It's safe to take if you've had a breast cancer. It's safe to take if you are on breast cancer treatment. Trudy, what we are doing at the moment is we're saying to people, if everything is beyond dry down there, use a little bit of KY, take something like Vagifem for 2 weeks until everything is pumped up and a little bit more fertilized, and then take it once a week or twice a week. And I'm comfortable with that.
Twice a week. So it's 2 weeks every day and then twice a week. It'll change your life, really.
100%.
Okay. Thank you very much. Well, let's hop on to our third category here. And Trudy, you mentioned the third most common cancer seen was ovarian cancer. Am I correct in that?
Yeah, but thank God, actually rare. It actually is not that common. It is rare. It is common in certain population groups. It is common in certain genetic population groups, but it is actually a relatively rare cancer. I mean, the average gynae would probably only see 2 or 3 in their lifetime. Fact.
Okay.
I mean, obviously, we're biased because we see it all the time, but it's not that common. There are population groups where it's much more common, and that's where your BRCA genes come into play, the genetic cancers. So it is unfortunately not screenable. That's the problem.
Okay,
that
so
answers
Trudy,
that
I'm
question.
going to ask you on that because obviously we encourage everyone, if you've got strong family histories of breast and other cancers, to do genetic testing. Remember, only about 8 to 12% of people with breast cancer have a positive test. You can still have a hectic family history and a negative genetic testing, and it's not just BRCA1 and 2, there are other genes that come into play, and we can be a little bit doff about not working out the combinations. So that is when you really, really need to have your checks and balances in place and work out what your risk. Say somebody has a BRCA1 and they've had a triple negative breast cancer, and you're going to recommend when you do preventive surgery. So firstly, how would you screen for an ovarian cancer?
So, I mean, there are risk-reducing strategies in those women. So, for instance, if they haven't completed their family, going on the oral contraceptive decreases their risk of ovarian cancer. For instance, we know sterilization decreases the risk of ovarian cancer because the tube talks to the ovary. It's very interesting. So what we recommend in those patients, only in those patients, is that we like to do a transvaginal scan every 6 months to look at their ovaries, and in between, so 3 months later, is do a tumor marker CA-125, knowing that a CA-125 is actually a bad test. It's a bad test in the general population because it can be raised for many things, from diarrhea to your menstrual period, to pancreatic cancer, to fibroids, to endometriosis. It can be raised for many, many things.
So I'm always quite clear with people because I often see, and I'm sure you do, general practitioners or other medical healthcare providers who've done screening tests on the blood, and then suddenly they have a high level, and then there's massive panic. Well, I think if you're going to do tumor markers, unless you're a guy from a prostate point of view, you really, really need to do it under the supervision of a specialist, because a high level does not necessarily mean a concern, and all it does is create more anxiety and panic. I mean, from the breast point of view, the marker, the 153, we only recommend in the metastatic setting to determine response to treatment. So doing it if you've got an early stage cancer or doing it as a screening is actually really not a good idea.
It is a terrible idea. It is my worst idea when they tick all those tumor markers. It really becomes so so frustrating because, like I said, it can be raised for many, many things, and it creates havoc. It creates havoc and panic. So ovarian cancer is a tough one. It is a tough one. So again, regular checks, that's all you can do.
And Trudy, you know what I'm fascinated about in oncology is how things have changed over the million years. So I always say in 10 years' time, when I'm happily retired, I was going to have a yacht in the Med, but after the yacht's going down and the this and that, etc., and besides the fact I'm still putting kids through varsities and this and that, I think I'll stick to something really, really simple. Maybe the Karoo is the safest place, but I think so. But what I really say to people, okay, is with all these checks and balances, okay, you've just got to have a sensible approach to everything. So on the ovarian side, there have been huge breakthroughs in oncology treatment. I know in breast that probably in 10 years' time we will probably not operate and just have the clever target treatment and freeze the cancer. And as ovarian cancer treatment improves, tell us a little bit about what's happened. And because I remember we used to do these radical surgeries, and now what do we do?
We still, unfortunately, do radical surgeries, but the one thing that has changed for us is a drug called a PARP inhibitor. So a PARP inhibitor is a drug that we use in BRCA genetic cancers, and that has improved survival for us. So it's the addition of a PARP inhibitor to chemotherapeutic drugs. We are experimenting a little bit with heated chemotherapy in the abdomen, but unfortunately, it is proving to be not as exciting as we thought it would be. And yes, the surgery, unfortunately, is still radical, that we need to try and remove as much of the tumor as possible. But the PARP inhibitor has really changed things. And so has another drug called Avastin, which is a bevacizumab, that has increased survival a little better for us as well.
So the PARP inhibitor is olaparib, and we also use it in breast as well. But I remember what we used to do is we used to start by debulking disease. Now, do we not often give chemos first and then?
So, I'm a believer, and there's good data to substantiate that you give what's called adjuvant chemotherapy first, and then you give 3 cycles of chemotherapy, and then we debulk the tumor, and then we give the rest of the chemotherapy, and that decreases the radicality of the surgery most definitely.
I'm going to ask you sort of a breast question. So with breast, what we're doing now is we use even an AI for 4 weeks, and if there's drop off on the Ki of the tumor, then we're like, wow, we know that endocrine treatment is effective in this cancer. When you start with your neoadjuvant chemo, and then you after 3 cycles go in with ovarians, do you look at things like Ki, division rate on cells, and determine response or anything like that?
So we look at the tumor marker, and we want 2 log regressions of the tumor marker. So we want it to go down mathematically quite significantly, and then we also re-image patients to see whether it is feasible. If it's not feasible, then we continue with the chemotherapy. It really also just tells you about the biology of the disease. You know, if it's severe, rapidly dividing cells, they're not going to respond as well.
And then
Doctors, if I may just interrupt you there, I am so sorry. And it is absolutely wonderful listening to 2 academics speak to each other and discuss this high-level medicine and the latest in breakers treatment regimes. But I'm going to try bring this conversation back down a little bit to the audience. We're talking about it, get it a little bit lay and off this amazing conversation that we're privy to. And I might ask a question or two that you might laugh at me for. But I know in previous webinars and experiences when it comes to breast cancer, that's my point of reference, is there's a big push on self-examination and self-checking. And for the last at least 3 cancers that we've discussed, and I'm not sure if it will go the same for ovarian and valvular that we're going to mention, is there any sort of way to check for signs and symptoms for any of these at home? What can I do in between doctor's visits or something along those lines?
So unfortunately, the uterus, cervix, and ovaries are confined within a bony pelvis, so you're unable to feel them yourself. But it is about symptoms. It's about irregular bleeding, bleeding after sexual intercourse, having a smelly discharge that persists. Those signs or those symptoms are really important. Obviously, on a vulvar cancer, that's a different story because the vulva, which is the lips, the labia, and the mons pubis, those are on the outside. So those are things that you can look at with a mirror, or your partner can feel and see, or you can feel and see. So for instance, if you have a sore on your labia that's not getting better. The other thing I must emphasize to everybody is don't let your doctor get away with writing a prescription without examining you. That drives me ballistic. If you are bleeding, the person must look. They must look inside your vagina. They must not just say, oh, you're bleeding here, take this medicine. Not good enough. We know that most women see nearly 5 practitioners before the diagnosis is made. It's abominable. Absolutely.
I fully agree with you. I absolutely fully agree with you. Have a check.
Ladies, you say, I'm not leaving here until you had a look. And if you don't want to have a look, tell me who will.
Yep, I'm with you on that.
You know, and a sore, if they give you a cream and the sore does not get better, you go back. Say, this is not getting better. What are you going to do about it?
Or I've had someone, well, we can just burn this off. That's another thing that I'm like, no. No one's burning anything. See a specialist, let them have a look and take a biopsy and have a look and see what's going on.
Take it off and send it away. We were always taught nothing gets binned. It all gets looked at.
Absolutely. Nothing goes to the barricades, eh? Yep. Okay. All right. Okay.
Fantastic.
So Dom.
Well, that is a lovely introduction to our final cancer that was mentioned, which was the vaginal and the vulvar cancers. You said it's becoming more common, but you did mention less than ovarian. What is your comment there?
So vaginal cancer is very, very rare. It hardly ever exists. But vulva, the outside lips, you definitely get cancers of those areas. In young women, it's usually human papillomavirus related, HPV related. And in older women, it's often related to a skin condition called lichen sclerosis. And lichen sclerosis is when your lips get thin and they get very itchy and you scratch, and they look white. Lichen is a white moss. And basically, if you form a sore that doesn't heal, that needs to be checked. And we know for lichen, if you itch, scratch, you need to use cortisone. Cortisone prevents cancer in those patients.
Great. I absolutely like that. So that's all the reason for have you check or have someone else check. And it's about know your bodies. And if there's something concerning. So I know we tell our teenage boys you shouldn't be itching and scratching there in public for no reason. And I think the same applies for us ladies. And I think often with ladies, we're embarrassed. People are embarrassed. And you shouldn't be, you know?
Never. We must make it sexy. The vulva and the vagina and the cervix, it must be looked at least once a year.
Right. Remind it to me. Don't even know when is. Okay. Okay, Dom, I'll hand back over to you around other questions.
There are not many more questions to go. I think the one thing we do have to comment is in terms of the treatment regime for these vulva or vaginal ones and that impact on childbearing.
And I think people are so scared of having surgery down there. Okay. And so maybe if you can just chat a bit about that.
So, you know, the vulva, if you've got a little sore there and it's not healing, it's very easy to take out a little sore and fix that problem. Because again, we're very fortunate that there can be pre-cancers of the vulva that are very easy to remove or use a special cream. It's called Aldara, which is the other name for it is imiquimod. So this cream makes your own immune system. Lots of dermatologists use it like on the face and on other areas when you've got little cancers, skin cancers. So the vulva is a skin. It's a skin like your head, your legs, your arms, any other skin. So we treat cancers in those areas like a skin cancer. So when it's tiny, it's easy to treat. It's when it's big, it's a bigger problem. Then we have to bring in special flaps, and it's big surgery. And sometimes even if it starts involving the bum, we have to do a colostomy. So it doesn't affect childbearing, but it affects sexual health if you have to do radical surgery in that area.
So what I also want to comment on is the amount of little old ladies that are sitting in old age homes or etc. I think it behoves us to be able to have open conversations with our loved ones near and dear, and to ensure and to make sure there's training available for particularly for people who are sitting in old age homes or frail cares, that whoever's doing their healthcare and their cleaning and their bath regimes, make sure that respectfully you have permission and you check. Because the amount of times I see people who well, I had something on my breast and, I didn't go for a mammogram and I couldn't afford it. And I just thought it was fine. And it's been sitting there for a couple of years. And I mean, like the lady I saw today with a big purple lesion coming through her skin. And why did she not come in? Because she was scared of surgery. So not everything has to be scary. And there are many other ways to do things. But if you're checking and sorting out, you need to have a good look. And what I like is I like working with practitioners such as Trudy, and I've known her for absolutely ever, and I trust her with my health, is because what happens is medicine is about taking a history and checking someone literally from top to bottom. And you need to have that relationship with whoever your healthcare provider is. And like Trudy said, is if you feel that you are being poo-hooed out the door or not being checked, and I'm very pro the concept of clinical associates and that type of thing, but it's not about handing it over to somebody else. You need to years of experience. Trudy, that's a polite way of saying we're older.
Absolutely.
But the concept is that you want someone to listen, take in, and realize when you have to check an action. And that is a big thing for me. The two of us work hugely with multidisciplinary teams. So it's not about seeing Trudy or seeing myself. It's about making sure you have access to a whole group of clever doctors who can help come up with a combined approach that's best for your healthcare.
Absolutely. And it doesn't, it's about you as an individual, and it's about back to basics. History, examination, then the special investigation. It's about, if you're worried about something, don't be afraid. We're always there for you. We're always there to look. We can say, no, don't worry, that's an ingrown hair, or that's a sebaceous cyst. That also happens. And then you can walk away and say, thank goodness, I didn't leave it too long.
Yeah, and remember also, as things change, do your mole mapping, check your gastroscopes and your colonoscopies. I think I'm also due that this year. And really just make sure, check your blood pressure. I walked into Dr. Van den Berg's room. He was checking his new machine, and I said, oh, quick, do your cholesterol, check your thyroid, just have an understanding of what's going on, what you should check and screen in your body. And then if you are uncomfortable about something, if something doesn't feel right, make sure that you've got a specialist team to help you. We know with breast cancer, we're doing lesser surgeries, smaller surgeries, more breast saving, more targeted treatments. Everyone's scared about chemotherapies. It doesn't have to be, and if it does have to be, we have navigators to help you through the program to ensure that you can manage, but leaving something is not an option.
Yeah, I fully agree. I can only but concur. We're there for you, and if the person is not there for you, somebody else will definitely be there for you.
There we go. Okay, Dom, I don't know if you have any questions in the chat rooms, any people who want to comment. It's
That's a
really,
brilliant
really
suggestion, Prof. I'd like to open up for anyone who's there. If there are any questions, anything that's over your mind, please post them in the chat and bring them through. We have one or two more questions. One which I'm hoping is a very simple, quick no. So I'll ask that first. Are there any other rare types of gynecological cancers that should be screened for or are not of concern?
No, there's extremely rare ones, but not of concern.
Okay.
Trudy, talk to me about people who say they've got fibroid uteruses and they have to have a hysterectomy for a fibroid uterus because it could become cancerous. I see that.
So fibroid uteruses very, very, very rarely become cancerous, 0.1%. Very, very rare. There are lots of new sexy things you can do to fibroids to make them smaller. Like, for instance, you can shoot tiny little coils to cut off the blood supply so that they shrink and die. And there's another thing that is just only available at Baragwanath, and that's called HIFU. That's high-frequency ultrasound ablation of fibroids that does not require surgery. So no, you don't have to have a hysterectomy for fibroid uteruses anymore.
Okay, fantastic. And the question that always comes through, and I'm sure you've answered a million times over, but it comes along the lines of managing menopause and managing side effects of HRT. I know you did touch on that a little bit earlier with some of the conversations. That must be a broad topic.
So it's a very, very broad topic. You know, I had a breakfast this Saturday with like 20 women who wanted to ask me questions on menopause, and it took us 3 hours. So how much time do you have?
Perhaps that should be
Well,
something that should be a webinar on its own.
As much time as you have. So thank you very, very much. And again, just even
I think even a webinar on it would be nice.
So maybe having it as a dedicated topic. I'm going to pin that, and I'll approach BHF, and I'm sure they'd be interested in hosting an evening along those lines. I haven't seen any specific responses in chat from any of the people watching. I'm assuming that's a good sign rather than a bad sign that we've answered most of the questions that we've discussed on out here. As always, I'm going to start off.
People mustn't suffer. So you mustn't, if you're suffering menopausal symptoms, don't be a martyr. Don't go and find out 27,000 supplements, vitamins, or as we've mentioned on progesterone creams and etc. Go and see a specialist who can give you sensible advice, who can recommend the right screening. And not everybody, so I always say HRT is not the elixir to youth, okay? We get older, okay? But life is about making sure you manage your symptoms so that you can have a quality of life. And Trudy, I think for me, what is important is that people who are on whatever treatment you're on, whether it's cholesterol treatment or HRT, you screen appropriately for what you're on.
Absolutely. That is the bottom line. It's somebody needs to examine you properly if you're on HRT, not just do a blood test.
Okay. I have had a question come through, and this was something I was tempted of asking myself because it's something that I've spotted on social media out there and heard from one or two friends as being a little bit of a boogeyman when it comes to gynecological issues. The question come through is, what is endometriosis? And from my own side, the question is, I've heard that it's a untreatable issue and we don't really know how to treat it. Perhaps a comment on that?
So endometriosis is when the lining of your uterus is found outside of your uterus in your belly. So the lining is on your ovaries or between your intestines. We've had patients with endometriosis in scars. I've even had one who had endometriosis in her chest. I had one actually who bled every period from her nostril. So it's when the lining of your womb is on the outside of your womb. So every time you have a period, it's subject to your own hormones, is that you bleed in that place. So basically it causes pain. It can cause pain of sexual intercourse. It can cause pain during your periods. It can cause infertility. And it does unfortunately put you at slightly higher risk of cancer. So it's treatment.
You know, my big thing is when I see moms with breast cancer, I'm big into saying when you've got children, it was a big thing for me. Girls at high school, if you've got pain during your period and they're like, man it up and just go to school,
No.
it's like a big thing for me. See somebody, nobody should be having pain and fainting around their periods.
Nobody. This is the modern era, guys. Modern era. And absolutely nobody should. So the treatment for it, we have a pill now. It's called Fazan, Dynagest. It's a high-dose progesterone. So remember, we're going back now to our uterine cancer story. If you stimulate the endometrium with estrogen, it becomes thicker. So what happens when you stimulate endometriosis with estrogen? It becomes thicker. So we use a high dose of progesterone, a progestogen, in fact called Fazan, to treat endometriosis in younger women. And when it's really severe, then a woman should have surgery. The problem is that, yes, it can come back. So you can control the disease, not necessarily totally cure it, but you can control it.
It becomes chronic, similar to my diabetes.
It's chronic. Yeah.
Okay. So I think the nice thing I want to just touch on is every now and again, I see something in the breast that's not a breast cancer. So Trudy mentioned endometriosis from the nose and elsewhere. I've seen ovarian cancers in the breast, etc. So not everything in the breast is a breast cancer. And there definitely is a tie-in between all our little bits and pieces. So that is why if you've got a lump in the breast and they firstly no surgical biopsies, if they do a needle biopsy and it comes back as something a little unusual, neuroendocrine, gynae, etc. I know Trudes often sit in the background of your very good Monday MDM. They are very, very good gynae oncology and specialist units that you can see so that we can manage what is not a breast cancer, but is a cancer, always something in the breast, or sometimes presents in the armpit or axilla as a gland. We see lymphomas, we see unusual things. So please make sure that you have that you are seen in a specialist unit that runs a robust multidisciplinary discussion to make sure that there is a sensible approach to your treatment.
Okay, I've got one last question from the chat that we will approach before we wrap up for this evening. And I do believe it's linked partly to endometriosis as to how one would diagnose that. But the question has a bit of background. This lady continuously has UTIs and has been put on Synapause because all other checks have come back clear. I have, I believe, severe dryness. Could endometriosis be a cause of that?
No. So, in fact, we know that the use of estrogen in the vagina actually decreases the incidence of, well, it obviously depends how old the person is, but decreases the incidence of vaginal dryness and of bladder infections. So women who use estrogen in their vagina, which Synapause is you can, in fact, Synapause dosing often is underdosed because the real dosing of Synapause is every day for 3 weeks. And so is Premarin cream every day for 3 weeks and 1 day off.
Okay,
So,
I've got a little bit more context from the patient.
yeah.
They're 48 years old and they're currently do have a bit of a cancer history as well. Their first cancer was estrogen driven. They're currently on Laradex and Crixana as they are on currently fighting a stage 4
and an
cancer.
AI. So Trudy can absolutely help, and we'll also recommend that they go and chat to her and see her, but she can absolutely recommend ways to manage the vaginal dryness. People always underdose.
Very dry. It makes it
Fantastic.
very, very dry.
Dr.
So
Smith,
it's not endometriosis. I promise them that.
okay. Dr. Smith, can
And
I
you
ask that
must
you just
manage-
provide some
you
contact
must
details for
manage-
yourself
Dom,
under this forum?
Dom, I just want
Sorry,
to
go ahead,
suggest
Prof.
you must manage your vaginal dryness because it's not just the dry vagina. It's the UTIs, the prolapse, the whole urogenital syndrome. Yes, it sounds like you and I need a date night with our respective partners. Okay, but the concept is people often underdose or start on a very low dose because they read a package insert that goes, don't take if you've got an estrogen sensitive breast cancer. And I'm going to encourage you all to have that conversation and make sure that you improve the vaginal I don't know, I don't think hygiene is the right word, but estrogen, whatever, health, till it's at a stage where you can then have a chronic approach to a lesser dose.
Yeah. So you need to build it up and then maintain it. So it doesn't really respond to little bits. It needs a proper thing and then maintain.
Thank you so much. Dr. Smith, if anyone who's listening in today would be interested in getting in contact with you, what's the best way to get through to you?
Well, they're welcome to email me on thsmith@mweb.co.za. If they've got abnormal pap smears, they're welcome to look at our website, ladydocs.co.za, and we'll direct them accordingly.
Thank you so much. And thank you so much for being part of this evening's webinar. And as well, Professor Benn, thank you so much. What I'm going to do is offer, as always, a chance for Louise to come and say a few words as the head of the Breast Health Foundation who chairs this initiative. Louise, if you're available this evening, let me just give you the ability to unmute yourself before I ask for you to unmute yourself. And then you should be able to talk.
Hi, good evening, everyone. Can you all hear me? Am I unmuted?
We can hear you, Louise.
Okay. Trudy, huge thank you. I know this was a bit of a date night change, but thank you for joining us this evening. I always love your talks because there's so much info that we just don't get to and don't always get time to ask our doctors. And Carol, as always, thank you for joining us. Hope you've learned something new tonight too. Thank you, ladies. And yeah. And to all our buddies out there, thank you for joining us. This will be available on YouTube, and I'm sure we'll send out the links on social media in the next few days. And I must say, I'm enjoying this Big Five. I think we are going to be broadening the topics quite a bit over the next couple of months, mental health and some of the others, because all of these issues affect us. Just because we're breast cancer and or cervical cancer survivors doesn't mean that the rest of the Big Five doesn't affect us as women. So, Dr. Smith, Prof Benn, thank you very much. I hope you ladies all have a good evening. And till the next time.
Thank you for having me.
Cheers. Thanks, Trudy, as always. Okay.
Thank you. And thank you, everyone.
Thank you. And thank you, everyone who attended. Please remember that these webinars do happen regularly, and we welcome you to spread the word. If you have anyone who you feel would be interested in listening in on some of our talks, they do get posted on the Breast Health Foundation social media, as well as Prof Carol's. Keep your eyes open for the next talk. It's coming soon. Thank you very much. Have a good evening.
Good night.